Hello, everyone, and thank you so much for joining me today on a very popular topic, achieving hormone balance using bioidentical hormones. This has always been a popular topic, but in recent months, perhaps become even more popular with the recent decision of the FDA to remove the black box warning of cancer from these hormones. And we'll be definitely talking about all of that as we go today. But let me start by introducing myself. I'm Dr. Hirani. I did my residency and board certification in family practice in Michigan. After that, I practiced for some time in a traditional family practice office and realized there was a lot of things I couldn't treat within the boundaries of mainstream medicine. That's when I decided to explore alternative medicine, now known as functional medicine, and here I am today, over 20 years later. I'm the medical director at Rose Wellness, and my approach is that I try to combine the best of both worlds. I use traditional medicine when absolutely necessary. My preference is to work with natural or functional medicine, where we really try to look for the root cause, see what's going on in the body, and bring the body under better balance. Right. So thank you. Let's get started here. We have a lot to talk about in a short period of time. You all will be getting a recording so that you can sort of digest through this whole thing at your own time later on. But I just want to kind of get some of the information out there, trying to really not only address what hormones are, what menopause is, and what hormone therapy is, but really hopefully trying to address some of the mystery around hormones today. Okay. So let's start at the beginning, the discovery of hormones. And one of the very first endocrine experiments ever recorded, Professor Berthold in 1849 did a series of tests on roosters. At that time, he was a curator at a local zoo. Well, what he did was he removed the testes from chickens, and this caused them to become kind of more docile. That aggressive male behavior disappeared, and interest in hens was lost. Well, then the next thing he did is he found that these castration induced changes could be reversed by administering a crude testicular extract. And basically, the chickens went back to their normal aggressive behavior. So when he put the testosterone in, that addressed the behavior. That's when it was discovered that there was some sort of substance coming out of organs, traveling through the blood, causing changes in function and behavior. So, what are hormones? Hormones are basically chemical substances that act like messenger molecules in the body. They're made by particular endocrine organs, go into the bloodstream, travel through the bloodstream, and get into another cell or receptor site in the body where they help regulate the function and behavior of that cell. This slide because it's important to understand that even though there's many hormones in the body, endocrine hormones, and for the purpose of our talk today, we're going to just stick to the female hormones, okay? But the female hormones don't act in a bubble in the body. It's not that once you kind of get those working well, suddenly magically you feel so much better. All the hormones kind of interact with each other. For example, if there's too much cortisol, maybe your progesterone, you won't be able to produce progesterone. If there's too much estrogen, you might not be able to produce adequate thyroid hormone, right? So each instrument in the orchestra has to do their part for us to get harmony and not noise, right? So if one instrument like the thyroid is playing beautifully, but every other instrument is not, you're still going to get noise. And vice versa. If you've got all the instruments playing beautifully, but one of them, like estrogen, is not playing well, again, you're going to get noise, right? So the balance is important. Hormones play a major role in our health and well being. They result in us feeling good. And when we have hormone imbalance, that can oftentimes be the result, or rather, be the reason for many chronic illnesses, including chronic fatigue syndrome, fibromyalgia, heart disease, autoimmune conditions, etc. By talking about one of the main female hormones in the body, estrogen. Okay. Estrogen is kind of a unique hormone in that it does a lot. It doesn't only work on menstruation and reproductive health, it affects it's got receptors in other areas of the body too. For heart health, it actually increases good cholesterol and reduces bad cholesterol. It helps to dilate our blood vessels, reducing blood pressure, and it actually reduces risk of plaque in our arteries. Estrogen also has a lot of metabolic regulations. It helps, prevent us from getting fat, overly fat. It helps with lipid metabolism, insulin resistance, helps support bone, thyroid, also helps support inflammation. plays a huge role in our on our brain function with mood and cognition. Huge role in our bone health. Keeps our skin elasticity and strong collagen tissue. And a little fun fact, estrogen, small amounts also play an important role in male reproductive health. It's actually important for sperm production and libido. Okay. So, things that estrogen does, it's a good hormone. We need it. So, if estrogen is so good, how can it be so bad, right? Everyone's heard about the bad estrogen. There's a lot of confusion surrounding that. In fact, a lot of female hormone imbalance conditions that menstruating or younger women deal with are related to either bad estrogen or too much estrogen. So everyone's heard of the phrase too much of a good thing can be bad. So if estrogen accumulates in the body, it may not be a good thing. How do we get too much estrogen in the body? Well, one common way is something called xenoestrogens. These are a bunch of estrogen-like compounds in our environment which act like hormone disruptors. And if too much of that builds up in our body, they disrupt our estrogen balance. Additionally, estrogen is a complex hormone. Once we kind of use up the estrogen, they break up into all these sort of offspring or metabolites, and then those offspring need to be packaged up and leave the body. But if it doesn't, and if those little, pieces of metabolites of estrogen are lingering around, then also we can accumulate too much estrogen in the body. And the liver and the gut play a very big role in releasing or getting rid of that excess unneeded estrogen. So we need good liver and gut health. It's not really a single hormone. It's a group of hormones. For our purposes, we're going to divide it into two categories. Internal estrogen, which is made by the body. You can see there's three kinds. The main estrogen is estradiol, E2. That's the one that creates our menstrual cycle and usually drops at menopause. That's the one that's popular in the estrogen patches, with replacement therapy that a lot of you may have heard of. What's known as external estrogens made out of the body. That could be birth control pills, it could be hormone therapy, of course, xenoestrogens, as I just mentioned, and then also phytoestrogens, which are found in plant foods like soybeans and flax. Some plants need estrogen too. Okay. So, what's the difference between the good estrogen and bad estrogen? What makes it good or bad? So, with hormones and their receptor sites, it's kind of like a lock and key mechanism. We need the right key for the right lock. And then once that lock unlocks, a certain function takes place that's meant to take place because of that hormone signal. So on the left side here, you can see estrogen going and binding to its receptor site, sending that message to the cell. And on the right side, you see a xenoestrogen displacing those original estrogens that are meant to be and taking up spots on those receptor sites instead, sending unintended signals. For example, good estrogen may say, hair, I want you to grow beautifully. And bad estrogen may say, hey, hair follicle, I'm going to weaken you, right? So there we go. Same hormone, estrogen, but it's actually not the same, right? So where do xenoestrogens come from? Unfortunately, they're almost everywhere. Okay, they're just environmentally everywhere. Now, you can see on this slide, and there's many more than beyond this slide. But even something like, for example, dental sealant, it's got a little bit of estrogen in it. And it's been stated that yes, it does have some mild estrogenic action, but it's very little, and it doesn't matter that much. That might be true for certain individual components, but when your overall threshold, when you're exposed to all of these massive amount of chemicals, you know, around you, of course, there's going to be an overall threshold increase of these xenoestrogens messing with those receptors in the body. In fact, a lot of menstruating women will find just by really trying to reduce those xenoestrogens or avoid those, they can really help a lot of their conditions, especially younger women. So, xenoestrogens have a very different profile in the body in terms of function, as we just saw, earlier with the good estrogens, right? It has a whole different. It can increase risk of cancer, obesity, poor metabolism, messes with reproduction and infertility. It can have metabolic effects, cause thyroid issues, and more. And there's a big box with and more because it really just goes beyond a lot of these conditions on here. So, pesticides in foods also tend to be problematic. All right. So that's kind of all about the xenoestrogens. Let's talk a little bit about how estrogen is eliminated from the body. So bear with me for a moment. We're going to go a little bit deeper and get a little bit more complex. Kind of created this analogy of the construction workers. Remember what I said before? When estrogen is either produced by our body or we take it in, gets metabolized into three other kinds of offspring: the 2-OH, 16-OH, 4-OH. The 2-OH is the good estrogen. It's very protective. Think of that like the cleanup crew. Does its job efficiently, protects our body from damage. Okay, it's very heart protective and bone protective. The 16-OH is and sorry, coming back to the 2-OH, we can actually influence how much 2-OH we have by eating more cruciferous vegetables, maintaining a healthy weight, regular exercise, and more. Okay. 16-OH, think of that as the overenthusiastic builder. It wants to keep adding more room, more wall, more tissue. It's useful in moderation, like in puberty and pregnancy, but we don't want that to happen all the time because if it keeps proliferating excess tissue in our breast cells, uterine cells, endometrial cells, then we develop conditions like fibroids, fibrocystic breasts, thickened uterine lining, heavy periods, PMS, etc. Okay. Inflammation, obesity, environmental toxins, and other things can cause more of the 16-OH. All right. Finally, 4-OH is considered the bad estrogen. It can cause DNA damage. It damages this building. We don't want this. All right. Poor diet, alcohol, stress, many other conditions and again, those environmental xenoestrogens can increase 4-OH. Right. So it's not just about how much estrogen you have in your body. It's also about what kind of estrogen metabolites you have and what those are doing to your body as well. Okay. And then, that was all part of step one, the break it down. Step two, package it up. So all of that excess bad estrogen then gets packaged up by our liver and gets sent to the gut. And the gut kind of acts like the garbage truck where it just throws out all that packaged estrogen out of the body, right? So that we don't have the unneeded amount. So you can see here, again, if there's issues or problems with gut function, microbiome, liver function, that's also going to influence how estrogen behaves in your body, right? So again, the big picture there. You can see, hormones are like Goldilocks. They can't be too high, they can't be too low. They've got to be just right. So here you can see the symptoms of low estrogen, symptoms of high estrogen, very different from each other. Low estrogen is mostly seen in perimenopause or menopause. High estrogen is typically seen more in younger or menstruating women, although it can be seen in perimenopause as well. So I'll let you kind of digest the slide on your own, but a lot of information on here on just some of the natural ways we can reduce or detoxify some of those xenoestrogens and bad estrogens. All right. So we talked about estrogen. The other major female hormone is progesterone. So these are partners, estrogen and progesterone partners, but they're very opposite to each other. Progesterone is the yin to the estrogen's yang. Estrogen, think of it as being more stimulating, energizing, movement. Progesterone's more calming and sedating. And of course, we need a balance, right? If we're overstimulated, we're going to have anxiety, insomnia, irritability. But if we're over calm, we're going to feel sleepy all the time, low motivation, maybe depression, right? So again, the right balance really, really matters. So you can see over here, the common symptoms of low progesterone are very similar to the common symptoms of high estrogen, okay? Because again, in a sense, they're opposite to each other in many ways. So, a common condition in again younger menstruating women and in perimenopause is something called estrogen dominance. What does this mean? It's a ratio thing. Basically, what it means is when you don't have enough progesterone for the amount of estrogen in your body. Okay. So estrogen, as mentioned, acts like a proliferator. It likes to build tissue. Think of progesterone like the manager. It says, all right, calm down, estrogen. We don't need you to build anymore, right? So things stay in check. If you don't have enough progesterone, estrogen goes crazy. It says, hey, no one's stopping me. I'm going to keep building. And some of the target tissues that it acts on are breast cells, fat cells, and uterine cells. So, of course, people with estrogen dominance are going to be more prone to fibrocystic breast cancer, thickened uterine lining, heavy periods, endometriosis, fibroids, ovarian cysts, et cetera, et cetera. Okay. And that's basically a lot of the hallmark symptoms as shown on this slide. So, how do you get estrogen dominance? Well, if it's a ratio thing, you either have too much estrogen or you have too little progesterone. Maybe you have a double whammy, right? You have both. Or maybe they're both normal, they're just off balance to each other. And of course, you want to treat what you see. So if you've got too much estrogen, you want to reduce it. If you've got too little progesterone, you want to increase it. Well, how do you know what's going on? Let's not guess, let's test. There are some tests we can do to help us identify what kind of targeted hormone imbalances we have, as seen on this slide over here. This is a urine test. On the top right box there, you see progesterone. Anything below that yellow star is considered low level. So this particular sample person has low progesterone. And then right underneath that, you see the three estrogen dials. The middle one is the estradiol that we spoke about, very high estrogen levels. So this person has estrogen dominance. And again, remember, it's not just the actual amount of estrogen progesterone, but that how the estrogen metabolites, how the estrogen is being used. And you can see on the pie chart here, this particular patient has very low good estrogens and too much of the bad estrogens, right? So again, we can then figure out targeted treatments, targeted therapies, targeted lifestyle changes, which can help influence this? Do they need progesterone? Do they need certain herbs or nutrients, and what kind of specific lifestyle changes they need to make? Some of the causes of estrogen dominance, again, the list is wide, but common causes include certain dietary measures, environmental issues, stress. Okay, and again, you might be taking too much estrogen through birth control pills or hormones. Now, in this whole presentation, I've just got one slide on testosterone, only because I don't want to forget about it. I want you to realize that even though testosterone is considered the male hormone, women do have some testosterone, just like we showed earlier, that men have some estrogen. And testosterone also plays an important role, aside from just libido and sexual health, on other areas of our body, including heart health and brain health. Okay. And so if testosterone levels, show up as low on testing, that could also be a consideration. For example, natural methods or a hormone to increase testosterone levels if and when needed appropriately. So now let's get into perimenopause and menopause. So this over here is a list of menopausal symptoms. You can see the most common symptoms are in orange: hot flashes, night sweats, etc. But a lot of perimenopausal, menopausal women will also get these vague symptoms like, I've got this burning tongue or electric shock sensation or itchy, crawly skin, and can't really understand where that's coming from. Believe it or not, those could also be symptoms of perimenopause or menopause. Again, these go wide. These hormones really go wide in our body in terms of what they do. I want a rapid heartbeat, and to get all hot, I only need to wait for my menopause symptoms. All right, so let's talk about that menopausal transition. Um, as you can see here, estrogen levels drop only by about 40 to 60% at menopause, just enough to stop the menstrual cycle. Progesterone levels drop much, much lower, including to almost near zero in some women. So before most women, before they actually hit menopause, they may have a relative estrogen dominance type of a pattern, right? Where, and I'm sure some of you can associate with this, where you're getting heavy periods and, constantly bleeding all the time, and you're just sick of it, right? And that's estrogen dominance. So it kind of comes back to this whole targeted treatment. Does every perimenopausal woman need estrogen patch and progesterone pill? No. In fact, in this case, if you take estrogen, you might be doing yourself more harm than good, right? So in this case, you probably need the progesterone if you have low levels to balance this out because it's already dropped. All right. So the pattern matters. Now, what's menopause? Well, every woman, of course, goes through menopause. The average age of menopause is about 48 to 52. Anything before that is perimenopause. And some women, perimenopause can be a month, right? You just suddenly, your period stops and you never have one ever again. Of course, that's rare. And in other women, may get periods here and there. They're irregular and slowly just kind of go away. All right. The definition of menopause is basically 1 year of no menstrual bleeding. And these days, women are spending more than a third of their lives in menopause. Of those women, 60 to 80% experience hot flashes or night sweats during and after transition. All right. Surgical menopause can occur too, of course, where if you have a hysterectomy and ovaries have been removed, you can suddenly be thrown into hot flashes and night sweats and into severe menopausal symptoms. Now, generally speaking, the median duration of hot flashes have been found to be longer than what was previously thought. 7 to 10 years, that's a long time. Now, some women are lucky, only last a year or two, and then they feel great. And other women, it can, continue onwards. And then 10 to 50% of women have persistent hot flashes throughout their lifetime. Now, a hot flash is not just a hot flash. It has a huge effect not only on your quality of life, but on preventive health as well, right? It can be very disruptive to sleep. It can affect your mood. It can affect your cognitive function. A lot of women, when they get a hot flash, it's combined with a lot of anxiety, jitteriness. It's just not a good, comfortable feeling at all. It can affect you socially. It can affect you professionally in terms of your functional abilities. And then, as mentioned, it's not, it's hot flashes are actually associated with worse long-term health outcomes. It's research has found that if the more severe your hot flashes, the higher the risk of heart disease or high blood pressure, high cholesterol, and high blood sugar. The higher the risk of inflammation and the higher risk of low bone density and fractures. Okay, so hot flashes are more than just a hot flash. Interesting slide on the effect of hormone on brain imaging. So, this is a PET scan done showing brain metabolic activity at premenopause, perimenopause, and postmenopause. The red color shows areas of maximum metabolic activity. The yellow green are less activity, and the green blue is very low to almost no activity. Look at how brain function declines, right, across that spectrum. And again, multiple researchers' studies has shown that during the menopausal transition, women's brain seem to age much faster than men's brain. Okay. And it's also been shown, perhaps, that estrogen therapy initiated within about 5 years of menopause, particularly during perimenopause, may protect against dementia, although more research is needed on that. So, if you have a risk of Alzheimer's, estrogen therapy might be something you want to consider, especially if, you're having those hot flashes and those symptoms. This slide shows the importance of, menopause and heart disease. Menopause leads to accelerated progression of atherosclerosis. Before menopause, men and women are at equal risk of developing heart disease. At menopause or right after menopause, excuse me, let me say that again. Before menopause, men have a much higher risk of developing heart disease, and women have a much lower risk. At menopause, it's equal risk. Okay. Not only that, but there's also a change in fat distribution, including abdominal fat, fat around the heart, increased cholesterol, blood sugar, and insulin resistance, and actual changes in the blood vessels also. Estrogen keeps our bones strong. After menopause, up to 20% of bone loss can occur right in the first 5 to 7 years. And research has shown that hormone therapy reduces hip fractures by about 30 to 35%. In fact, HRT is one of the most effective options for preventing bone loss in early menopause compared to any medication out there. I'm a victim of identity theft. Menopause took a happy, slim, sexy woman and turned her into me. How many of you feel like that? How do we treat these hormone imbalances? Well, always, number one, we look for the underlying causes. Why are they out of balance? What kind of imbalance do you have, right? Are other organs or systems in your body playing a role? Very important, of course, to pay attention to targeted lifestyle changes with a balanced diet, exercise, sleep management, stress management. There are lots of natural herbs and remedies we can use out there to help with hormone health that are targeted. And then, of course, bioidentical hormone replacement therapy. Again, today's talk is about hormone therapy, so we're going to jump right into that. So, replacement therapy is when you take hormones because the ones your body normally produces are either low or out of balance. Now, in the past, um, you know, this was much more um, yes, hormones were given much more aggressively. All right. Oh, you had so much hormone when you were menstruating. We need to give you a lot of hormone now in menopause. Now we understand that even low doses can really make a significant difference. We're not trying to replace your hormones. We're just trying to give you a little bit of hormone back to help not only with quality of life, but perhaps with preventive health. Not perhaps, proven with preventive health as well. So how does hormone therapy work? Well, on that, we're looking at a healthy bone cell, okay, and the hormones like estrogen. So in that first slide there, you can see in a healthy bone cell that has adequate hormones, those minerals are getting in there nicely and healthily. In the second slide, when we've got low hormone levels, all those minerals are leaking out of the cell, right? Not a good thing. And in the third one, when we put the hormone back in, those minerals are retained. All right. So again, the lock and key mechanism, important to have there. Right. So me through this slide. I just find this fascinating, the history of hormone replacement therapy. And I think it's important to understand that so that we understand why there's so much controversy and fear around estrogen in general. So, estrogen. HRT or hormone therapy has had a very tumultuous history from glamour to controversy. To me, it's just been shrouded in mystery because I never really understood why there's so much fear surrounding hormones when there's so many other medications and therapies out there that are more dangerous than HRT, but not really questioned that much. So, anyway, in the 1920s and 30s, doctors found that women that had premature removal of their ovaries before menopause actually had increased risk of heart disease and early aging. So, it was theorized that estrogen played a key role in anti aging benefits. So they really, started working hard and extracting, trying to find hormone in a bottle. So they finally extracted a substance from pregnant mare's urine and they called it Premarin. This was the first synthetic estrogen approved in the United States and it became widely used for menopause. So suddenly there was this magical anti aging potion that was created. And there was a lot of aggressive marketing around Premarin. It was promoted to keep women, quote unquote, pleasant to live with and youthful. This happiness continued into post World War II era. And by the 1960s, estrogen had become one of the most widely prescribed medications in the United States. In the 1960s, a book came out called Feminine Forever. This was written by a gynecologist and became an instant bestseller overnight, promoting estrogen as youth in a bottle. The problem with all those eras, though, was that medical regulation and the FDA as we know it today didn't really exist. So when doctors were prescribing these hormones, they were essentially conducting this huge experiment uncontrolled on the female population. What were the risks? Well, no one really knew, and frankly, no one really cared. Soon, reports started to come out of estrogen therapy being increased risk of endometrial or uterine cancer when used alone. So, in 1970s, doctors started to add synthetic progestogen to women that had a uterus, and suddenly the risk of uterine cancer reduced dramatic, or the rates of uterine cancer reduced dramatically. And by that time, numerous other studies were done which suggested that HRT had many benefits, not only with menopausal symptoms, but also to help prevent chronic diseases. So the idea kind of switched from feminine forever to healthy forever. In fact, by the 1990s, not too long ago, prescribing estrogen or hormone therapy became standard of care. Anytime a perimenopausal woman walked into her doctor's, office, the doctor would start to recommend and prescribe hormone replacement therapy, not only for symptomatic control, because it also treated long-term medical complications of menopause. All of a sudden, the big earthquake hit in 2002 when the results of the largest clinical trial in medical history were announced. This was called the Women's Health Initiative Study. The results of the study were sensationalized and announced via media. This was supposed to answer the question, well, that eternal question, was hormone therapy actually the miracle treatment everyone thought it was? Well, at that time in 2002, there was a huge emphatic no to that answer. Okay. Why? Because it was sensationalized that hormone therapy increased risk of breast cancer, stroke, and blood clots. Wow, what happened, right? The medical community was stunned. Patients became terrified. Literally overnight, millions of women stopped taking these hormones that they told were essential for their health and well being. Prescriptions dropped significantly worldwide. That's when the FDA applied boxed warnings to these hormones, indicating increased risk of cancer and heart disease. Menopausal education in medical schools and residency basically stopped, and there was a whole generation of doctors until today that's never really felt comfortable with prescribing hormone therapy for menopause. That's when bioidentical hormones started to become a lot more popular, and the functional medicine world kind of took over that department. Okay, where functional medicine doctors continued to promote bioidentical hormones, and HRT was one of the major treatments seek out by women that were perimenopausal and menopausal, were unable to get hormone therapy, or really just didn't know what else to do. It's not just about, replacing hormones. Like, what do I do during perimenopause, menopause? I'm feeling so miserable. What am I supposed to do to feel better? And functional medicine kind of, really kind of took that guidance role. Okay. Anyway, you can see there in 2017, that same researchers that did the initial WHI study did another study as an 18-year-old follow-up, which they published in the Journal of American Medical Association. And what they did is they re-evaluated that original study. And they also found that long-term outcomes found no significant increase in overall mortality or lifespan in women who took hormone therapy compared to placebo. And it showed that the risks and benefits varied by age and timing of when you started the hormone. What just happened there? How did it go from this is dangerous poison to, hey, this might actually be good for you? Well, we'll talk a little bit more about that. I'm going to actually get into the meat of this in just a moment. However, as most of you are aware, very recently in 2025, the FDA finally initiated uh, the removal of the long-standing black box warning from hormone therapy products. Okay, they are specifically removing warnings related to heart disease and breast cancer and dementia, but they are keeping the warnings related to uterine cancer for anyone that's taking unopposed or estrogen only. So let's talk a little bit about what that Women's Health Initiative study was, that original 2002, dangerous study. Basically, it was a huge study, and they divided all those women into two groups. One group got synthetic estrogen, the other group got synthetic estrogen and progesterone together. It was supposed to be an 8-year study, but they actually had to stop the study in 5 years because of the significantly increased risk of breast cancer, strokes, heart attacks, and blood clots. Okay. That's, of course, when hormone therapy stopped. When they reanalyzed that study in 2017 and they really kind of looked at it, they said, hey, this was a very flawed study. All right. First of all, nearly 70% of the women in that study were already over the age of 60 when they started hormone therapy, over a decade past the average or typical age of menopause. And a lot of these women already had heart disease and risk factors associated with heart disease, like high blood pressure and diabetes, obesity, etc. Okay. So, what they found is when they only examined those 33% of people that were within the 50 to 59-year age group, they actually found a very different profile. What they found in that situation was that estrogen therapy actually reduced the risk of breast cancer, heart disease, and all cause mortality. In other words, dying from any cause. That's significant. Okay. So, again, timing and age matters. So let's take a look at that. You can see over here in that, again, the 50 to 59-year-old age group, and keep in mind, these are people that were taking synthetic estrogen, Premarin. We're not even talking bioidentical here. Synthetic estrogen, the 50 to 59-year-old age group that took it, their risk of heart disease and breast cancer actually reduced, not increased. Even in the 60 to 69 age group, the risk of breast cancer and heart disease actually reduced. However, by that age, the risk of stroke and blood clots went up significantly. Okay. In the estrogen and progesterone therapy group, here, even the 50 to 59 age group, the risk of breast cancer and stroke went and heart disease went up. So what's it tell us? It was the synthetic progesterone all along that caused those increased risks, not the synthetic estrogen. Poor estrogen had such a bad name all these years, and estrogen was never even the culprit. It was the synthetic progesterone that caused these issues. Yes. In this age group of 50 to 59 years, in either group, the estrogen group and the estrogen progesterone group, the number of conditions which actually improved with hormone therapy. Last one there, diabetes. Diabetes went down by 26 points just by starting estrogen. Okay. All fractures went down, all kinds of cancers went down, including colon cancer and including breast cancer. That's pretty impressive. What does the evidence show in young postmenopausal women? HRT reduces the risk of death due to any cause by 31%. Okay. In fact, even aspirin and statins have not been shown to reduce the risk of all cause mortality in women like HRT has. And the slightly increased risk of breast cancer that progesterone showed, it was just a small risk. Basically, one extra person would get breast cancer for every 1,000 patients that took the combo of synthetic estrogen and progesterone. That's less risk than the risk of 2 glasses of wine a day. Similar or lower risk than with obesity, sedentary lifestyle, and many other commonly used medications. And of course, since then, there's been numerous studies that have come out which have shown that bioidentical progesterone is way safer than synthetic progesterone and does not cause those same risk factors at all. Okay. Well, one of the most common risk factors we saw was blood clots. Okay. Now, the reality is, in healthy women that don't have a risk of blood clots, the probability of getting one is generally very low. In fact, very similar to the risk of getting a blood clot for birth control pills. And yet, how many women are on birth control pills? Right. The risk does increase with age and the presence of other diseases and risk factors. And it's more dangerous in pill form. So, oral estrogen in a pill form, when you swallow it, it goes through the liver first and then goes into the bloodstream, making the blood kind of stickier. Whereas if you're taking estrogen through, like transdermally through a patch or a gel or a cream, it goes through the bloodstream first and then through the liver, which actually makes the blood less stickier. And therefore, the risk is significantly lower when you take bioidentical estrogen through your skin compared to a oral medication. All right. All right. And with vaginal estrogen, by the way, no, none of these same risks were shown. So, of course, there's been more studies since then, but even in 2015, when they did a meta analysis of 19 trials and 40,000 postmenopausal women, the conclusion that they really came up with that when you start hormone therapy within 10 years of menopause, it reduces heart disease by 48%, reduces death by 38%. So, therefore, hormone therapy is beneficial for the right patient. Who's the right patient? The right patient is someone who is experiencing moderate to severe menopausal symptoms under the age of 60 and within 10 years of menopause that doesn't already have heart disease or other cardiovascular risk factors. That is the right patient. Okay. And not only, do you prevent these risks, but again, you can have so many other benefits as well. Now, in the, 60 to 69 age group, it's not an absolute contraindication with caution, depending on the person and the individual. It might be beneficial to take hormones as well. But again, the increase of stroke, the risk of stroke and blood clots can go up higher at that age. Again, it depends on your other risk factors and who you are. The American Heart Association in 2020 said that the benefits of hormone therapy, including lower rates of diabetes and protection from bone loss and insulin resistance, outweigh the risks for the majority of early menopausal women. Between synthetic hormones and bioidentical hormones. Well, one of the major differences between them is, how they're made. So, as mentioned before, Premarin or synthetic estrogen comes from pregnant mare's urine. And although technically it's natural to horses, it's not natural to women and tends to make a lot more of that 4-OH, okay, or inflammatory compound. Whereas bioidentical hormones derive from plant sources, typically, soy in our country, but yams as well. And it's chemically identical to the hormones in your own body. All right. Bioidentical hormones now, after many years and multiple research studies, have been found to have much fewer side effects than already what we even saw there, which wasn't a lot to begin with. The nice thing about bioidentical hormones, I want to really clarify here that the estrogen patch and progesterone pills, which have become so popular now through even conventional medical doctors, help a lot of women, but It may not in some women. Some women may say, well, I tried that, it didn't help, or I had side effects. Remember, again, I want to emphasize the point that it's much more complicated, right? There's many things we definitely need to look at in the body. However, sometimes, one dose is too high. Like, for example, progesterone, the smallest dose it comes in the regular pharmacy is 100 milligrams, and some women really need progesterone, but 100 is too high. So what do you do then? So then we can individualize it through a compounding pharmacy. But that estrogen patch and gel and the prometrium progesterone pill that are mostly being prescribed today are bioidentical. However, you can also get bioidentical custom compounded formulations through a compounding pharmacy for more precise dosing and also for just different forms if these forms are not working for you. You can get patches, creams, pills, troches, sublingual, shots, pellets, etc. Ideally, each patient should be monitored carefully through regular follow up hormone panels to obtain symptom relief at the lowest possible dosage. I want to put a little bit of a slide about media influence over here because, this just played such a big role, a major role in how the public viewed hormones. The media, in its rush to communicate those, initial 2002 WHI findings, oversimplified the message. They said all hormone therapies for menopause should be avoided due to risk of breast cancer, right? Because there was these sensational headlines and the way they framed it. And of course, there was this huge public reaction to that and unfortunately created long-term negative impact. Good science became distorted and ultimately caused substantial and ongoing harm to women. And there's a whole generation of women that may not have benefited, from the hormone therapy. Thankfully, things are changing, right? Recently, things have changed, not only with the 2017 reanalysis of the study. I want to point that out too. When they reanalyzed that study and they said, hey, things are really good, and all the other studies that came out afterwards saying, hey, things are really good with hormone therapy, where was the media then, right? Why didn't the media come out and say, guess what? Hormone therapy does not cause breast cancer. In fact, it reduces risk of breast cancer. So there really just hasn't been a lot of that. Now, recently, again, the FDA has kind of changed that decision based on good science through the years that it's going to remove those black box warnings. And suddenly, very recently, just in recent months, hormone therapy has become popular again, right? More women are starting to say, maybe that's a good thing. It doesn't cause cancer. Should I look into it? Should I not? Right. And that's what a lot of this talk is about to help you understand if you are the right candidate or if you're not the right candidate for it. Okay. And again, also, really, again, I didn't get into a lot of the other treatments, but there are many ways we can treat perimenopause and menopause. Hormone therapy is one of those options, especially if nothing else is working or if you've got severe symptoms or severe risk of health issues because of menopause. So the pendulum swung and hopefully now finally balanced, right? In the early years, hormones were being prescribed as a panacea to all women, marketed as the fountain of youth. Then, after the sensationalized 2002 study, the pendulum swung hard in the opposite direction, from universal recommendation to widespread avoidance. Today, we know the truth is much more complex. And hopefully, today, we're utilizing a more balanced approach, which came about through a hard won journey towards evidence based care. So, slowly, there's now a shift in mindset from viewing hormone therapy as either a miracle cure or a dangerous poison to understanding it as a tool, among many others, for supporting health and quality of life during that, for some women, difficult menopausal transition. Now, I also want to kind of say that yes, menopause is a natural phenomenon, it's a physiological change. Does every woman have menopausal symptoms and issues? No, not by any means. Okay. But we do live in a more toxic world. We do live in a more stressful world. We are living a lot longer than women in the past. So there's lots of different changes that have occurred, which can influence why we're so much more symptomatic and why we have so many more health conditions related to menopause and beyond. Okay. So, the functional medicine approach really emphasizes nuance, individualization, and evidence based care. It's not a one size fits all treatment. There's careful consideration should be taken of timing, how old you are, right? Dosage, delivery method, what your goals are, and what are your risk factors. And again, most of the preparations nowadays really are bioidentical. Rarely are the synthetics being used anymore. Remember, those are chemically identical to the hormones our own body made during, menstrual life. There's multiple delivery options based on your comfort and what works best for you. And there's a shared decision making, or should be, between the patient and the provider, right? So the focus has shifted from chasing eternal youth to addressing specific measurable health concerns. And the benefits are balanced with clear risk discussion and ongoing monitoring. And again, the personalized functional medicine approach takes all of that into account, with the key principle being tailor the treatment to the individual, not the individual to the treatment, right? So we can use advanced assessments, checking hormone levels, genetic factors, cardiovascular risk markers, metabolic markers. Individual factors matter. Again, your age, your genetics, your medical history, your lifestyle, your personal preferences, and that flexible approach. Do you want hormone therapy? Do you want alternatives? You want to use short term? You want to use it long term? What are your goals, right? So complex, but hopefully one of the main things I wanted to do in this talk was really kind of unravel some of these mysteries and how hormone therapy has been viewed across the years to the very present. Okay. So turn T or not, ultimately it's your choice. While we can't promise staying feminine forever, we do focus on individualized care and an evidence-based approach designed to support your health, vitality, and quality of life during this important transition of women's lives. All right. Thank you so much. I know that was a lot. Again, you will be getting a recording of this whole presentation so that you can kind of watch it a bit more slowly and at your pace and your comfort level. Rewatch some things, that you want to. Um, and at this point, I will kind of give you all a chance to chat, in the chat box. Go ahead and feel free to ask any questions you would like to ask. Please feel free to ask whatever questions. I will slowly kind of read through them and address them as we go here. Um, please feel free to contact our office. The information is on this slide. We are accepting new patients, and please keep in mind it's not just me, but also our my colleagues. We all at Rose Wellness kind of treat hormone and functional medicine with the functional medicine approach in the same way. All right. So you're welcome to see any of our practitioners at our practice or call our office with any questions you have regarding any of this. All right. I'll give you a couple minutes for questions and then we'll go from there.